Good afternoon, everybody, and thank you. I don't really mean to stand in between you and an illustrious surgeon who will be talking about D2 dissections and, of course, lunch. I'll make sure I stop at the right time. I was expecting both Bharat and Rajesh to finish all the studies, so I'm not going to show you any study at all. What I will try and do in the next 7-8 minutes is, I'm glad the clock is still not there, is try to give you a slightly different perspective of all the numbers that people have been showing since mid-morning that I reached here. And I'll also try to give you a flavor of where this field is actually moving. So if you're going to think that what I'm going to say is going to be applicable on Monday morning, you're certainly going to be disappointed. So I will leave you with more questions than answers at the end of this talk. Both Rajesh and Bharat showed you Matterhorn and so many of these other studies. Now, I've got 3 curves that you're seeing on this Kaplan-Meier projection. The green one is when you add immunotherapy to FLOT. The purple one is when you just do FLOT. And the one at the bottom, which I have drawn, this is not a randomized study, I have drawn this third curve, is what you get with ECX or EOX, which is what we've been doing. It suddenly becomes 7 minutes, okay. ECX and EOX, which we've been using for a long time. Now, Bharat showed you very nicely that you jump up between 5%, 10%, 15%. Let's look at this in a slightly different fashion. Now, remember that this is the event-free survival curve, and at the end of 2 years, if you just did EOX or ECX, 43% of patients don't get a recurrence at all. That means they're quite happy, we're quite happy doing ECX, EOX in this set of patients. There's another set of patients, which is about 33%, who are still getting recurrence when you do the best available regimen today, which is the Matterhorn regimen, FLOT plus an immune checkpoint inhibitor. Okay, so 43% don't need beyond ECX, EOX. 33% of patients need well beyond what you are calling as the best today. What happens in between? You get a 16% incremental benefit with FLOT, which means for one recurrence to be prevented, you have to treat 6 patients with FLOT. Okay? For one recurrence to be prevented, you have to treat 6 patients with FLOT. And if you want to add immune checkpoint inhibitor, what's the benefit of that? In order to prevent one recurrence with an immune checkpoint inhibitor, you have to treat 12 patients. Okay? One recurrence, 12 patients. That means every 12 patients, you'll prevent one recurrence. 11 patients don't have any benefit out of this intervention. Similarly, number needed to treat is 6. 5 patients out of every 6 don't have any benefit out of adding FLOT. So do we really know who are these patients who are benefiting from this intervention? Unfortunately, no. We don't have a clinical biomarker. We don't have a lab biomarker that we can test to say, okay, this is the guy or the lady sitting in front of me who needs FLOT, or this is the patient sitting in front of me who actually needs an immune checkpoint inhibitor. What are we doing these days? We are doing something called as a conveyor belt approach. Everybody who comes in will be discussed diagnostic laparoscopy. You put a chemo port in, and then you say, I want to do FLOT for you, and then we will send you to surgery after 4 cycles. We'll get you back, do 4 more cycles, and you're going to be cured, let's say 50%, 60% of the times. I think we should clearly move away from this conveyor belt approach and try to personalize. You've been hearing FLOT all the morning. Remember that when you start doing FLOT, 90% of patients who started FLOT will get to surgery. When surgery is done and patients come back to you, 25% will not start any further treatment at all. Okay, 25% don't start any treatment after FLOT and surgery. 50% of patients don't complete FLOT. Okay, 25% don't even start the adjuvant FLOT. 50% don't complete FLOT, but that's exactly what we keep talking and telling patients as if it's some cakewalk. You get flot, you get a surgery, you get flot, and you go home. That typically does not happen. So the question is, if somebody looks really shaky after surgery, do you really need to push these patients to get flot? There's a nice retrospective study called as the space flot. What did they do? Australian and European investigators looked at 1,600 patients who had undergone flot for stomach cancer, and they tried to look at who are these patients who are actually benefiting from the second half of the flot, which is the post-surgery part of the flot. Now, if you had a pathological complete response, which means when you had surgery, they didn't find any tumor at all, that is a patient who is less likely to benefit from the adjuvant part of the flot. I am not telling you don't do adjuvant flot. What I am trying to tell you that if you have a patient who doesn't look fit enough to undergo the adjuvant part of the flot, and if that patient had complete disappearance of tumor at surgery, it's okay to let that patient go home. You need not do the adjuvant part of the flot. The other set of patients who don't benefit is patients who didn't have any response to flot at all. You started with the T3N+, they went to surgery, your pathologist said, sir, your treatment has not worked at all. If your treatment has not worked in the neoadjuvant setting, it's very unlikely that it will work in the adjuvant setting also. So if you have a patient who's had a super response, or if you have a patient who's had no response, both of these groups are unlikely to benefit. It's the patient who's had some response to this neoadjuvant therapy who is likely to significantly benefit from the adjuvant flot that you want to do. Again, let me make it very clear, I am not sending the message here that some patients need not have adjuvant flot. All that I am trying to say is that if your patient doesn't look fit enough to go through the adjuvant phase of the therapy, it's okay to leave some patients not taking that flot. Bharat showed you 1 full year of durvalumab, which is adjuvant therapy. Terribly expensive. I don't even want to tell you what that number is. Most of you guys will run out of the room.